Mine is also recorded.
Very good morning to all. I thank PCSI for this opportunity. I'll be presenting device closure of atrial septal defects with marked malalignment, the lessons learned over the years. Septal malalignment is a risk factor for failure of ASD device closures, and it is quite challenging for device closure of ASDs malaligned. The septum primum, as you can see in this picture, is malaligned towards the left atrial side, and the separation of septum primum and septum secundum, as depicted by the dotted red arrow. It is difficult to recognize it by transthoracic echo and typically visualized in, as is shown in this picture, as by TEE, mid-esophageal TEE, 45 to 90 degree sector. There's limited literature available on closures. We have three cases: a 33-year-old lady with a 20 mm ASD by transthoracic echo. She had a malaligned IAS with a 23 by 16 mm ASD by transesophageal echo. As shown in this pictures, you can see that the postero-inferior rim is attaching to the anterosuperior aspect, well away from the aorta towards the right pulmonary artery, or between the gutter, between the right pulmonary artery and the aorta. So this, though we expect it to join here, abutting the non-coronary cusp, it is joining here. So this triangle is what is concerning, and device sizing must be measured based on this diameter rather than this diameter. You can also see another patient with a 20 mm ASD by transthoracic echo with significant malalignment. You can clearly make out how significant you can underestimate the size of the ASD if you are measuring only in one plane. This measured 29 millimeter, and the separation between septum primum and secundum measured 12 and 11 millimeter in these two patients. There was this 80-year-old patient with 12 mm ASD. On TE, it measured 17 by 15 mm. And here the separation between septum primum and secundum was 8 millimeters. You can see in 0 degree, there is only when the aorta is seen is the ASD visible, and the other views 48 and 90 degrees representing the significant malalignment. And this highlighted area represents the plane, the triangle plane between the septum primum and the septum secundum. So the still images showing the same features, the orange line representing the actual attachment of septum, and the blue line joining the rim to the non-coronary cusp, abutting the non-coronary cusp. And you can see that this actual defect size is slightly more than what would have been measured by the typical conventional methods on transthoracic or transesophageal echo. So this needs to be recognized. These patients, the first patient underwent ASD device closure with a 26 mm device, but it embolized to the left atrium, which had to be retrieved surgically, and she underwent device surgical closure. The second patient, the 8-year-old, underwent successful device closure. You can see in this patient, the device is well splayed in 90 degree view across the anterosuperior rim. This is the aorta, and same shown on 45 degrees. Whereas in the first patient, you can see that across the anterosuperior rim, the device is not what we would like it to be. It's not very well splayed, and there's kind of a pinching here, which means that the entire rim may not be within the disc, which is seen on 90 degree and 120 degrees too. This must have led to the embolization in this patient. The same still images of all the three patients, which is showing the not so good position with mild pinching here versus a very good splaying across the anterosuperior rim in both the successful cases. So septum primum is malaligned towards the left atrial side, and the defect surface of septum primum is different from the septum secundum. This is ideally measured in TE 45 to 90 degrees. The clues are in 0 degree, you will not visualize the ASD until the plane of aorta is seen. And there may not be an ASD seen in a typical bicable view. The aortic rim is absent, and the appearance that the rims are joining towards the right pulmonary artery, or the gutter between right pulmonary artery and aorta. This is our own experience from Srijitra, 240 significantly malaligned ASDs out of 2,600 device closures. Incidence of malalignment being 10.1%. We did sizing entirely based on TE and did not have any erosions, had 3 embolizations, and 39 underwent surgical ASD closure. So what are the implications? It is important to recognize septal malalignment. The 45 to 90 degree TE is important for visualization, and is better to appropriately upsize the device size based on the ASD diameter at the septum primum ideally plus 3 or 4 millimeter to prevent embolizations. Device must enclose septum primum and septum secundum in between the disc without either disc being wedged in between the septum. And the splaying should be ensured on TE 90 and 120-degree views. Thank you for your patient listening.
Thank you, sir. That's a fantastic presentation. Now, obviously, the initial assessment becomes the key in terms of success for this malaligned ASDs. With regard to your transcatheter echo assessment, does the 3D echo adds anything to your assessment in terms of device selection?
For the cases illustrated, only the 8-year-old we have done a 3D, and the other cases we have not done a 3D, but it significantly adds in that the actual device, actual defect size, we tend to rely on 3D if it's a very good image. Unless it's a very good image, you can't rely on 3D for sizing. So if the 2D images are good, then only you get a good 3D image. So unless you get a good 2D, the 3D images will be bad. So we tend to rely more on the 2D for the sizing.
Absolutely. And I think there was a question about oversizing, which you already answered, I think. So you can comment on that. How much oversizing should be done?
So, if you see all these 3 cases, we have done +3. It was the second case was asked, especially that was 17 by 15. So we did a 20 mm device. And one of the published studies also mentions that we tend to underestimate it by around 4 millimeters, the distance, and hence the defect size.
I invite the other chairpersons, if they have any questions to put forward now, please. Yeah. So we'll probably have more discussion after the next talk as well. I invite Dr. Kalyana Sundaram from Coimbatore, GKNM Hospital, to share his abstract, please.
Yeah. Good afternoon. Good morning to everyone. I thank the organizers of PCSI 2021 for giving me the opportunity to give the oral presentation of my abstract. I have a 2-portion part of this talk. One is transcatheter closure of ASD with the TE guidance, having problem and how we circumvented that problem, and followed by my study on this, whether can do away device closure of ASD with of a T-guided procedure. Okay, so I move on to my talk. So it's my abstract is transesophageal echocardiographic probe is a hindrance for LA disc deployment in ASD device closure. Over 3 decades, transcatheter closure of ASD is established and a safe procedure, and it is being performed routinely under a T and fluoroscopy guidance. Last decades, we saw many centers started to do transcatheter closure of ASD under TT and fluoroscopy guidance. Some centers they do only TE guidance, and some centers do only TT guidance, especially from China. They do many interventions without any fluoroscopy. Advantages of T-guided procedure is clear images because the T probe is very close to the left atrium. Disadvantage of the T usage is potential injury to the throat and esophagus, causing throat pain, mucosal bleeding, aspiration, and incurring additional T cost. So I am going to give a few video clips where under T guided procedure, where he had a problem, then how we circumvented that problem. First case, you can see that's a 22 years old female, large ostium secundum ASD, and then we are able to close with that one. Second case is a 18 years old female with a large ASD. Then we close this defect with T guidance. Third case is a 21 years old male with a large ASD. Then we close this defect with 24 mm device. Fourth case is a 34 years old female with a large ASD, close with 28 mm device. So all these four examples, did you see anything? So you probably you may observe. I'll just explain again another fourth one. Just see that, look at that. See the TE probe, look at the, try to pull it down, it's not coming down. So that you can see the TE probe just, it's preventing the LA disc coming and aligning with the atrial septum. Once I remove the TE probe pop, it's coming and aligning nicely. So this was the problem actually. It happened once accidentally, then we try to do it this way. Whenever it gets stuck in the middle of the LA, then we just pulled up, it's got aligned with itself. So failure of LA disc aligned with atrial septum when T probe was behind the LA. LA disc aligned immediately once T probe was pulled up. So this cause of this problem probably due to compression of LA by the TE probe. So this successful deployment technique encourages us to apply in our subsequent patients whom we face the similar difficulties. Probably roughly about 50% of patients have the similar problem. Then based on that, thought of do a study on that prospective study, whether you can do away with the TE, how much, what is the problem. Okay, so we selected all the groups, age groups, there's no age biased. So out of 173 patients diagnosed to ASD, only 13 patients were included in the study. 60 patients were excluded from the study because 36 patients had poor image quality by TT. So we electively did under deep guided procedure. 24 of them had insufficient rims, so they were sent for surgical closure. So symptomatic patients, the age size of more than 8 mm and the right heart dilatations were included in our study. The age group of our study population range from 7 months to 75 years, median age of 6 years, and the weight of the study population range from 5.5 kg to 84 kg, median weight of 16.5 kg. The size of the defects range from 8 mm to 36 mm, median size was 20 mm, and 2 patients had 2 defects. Out of 113 patients, 109 patients underwent successful TT guided procedure. 4 patients on table, we could not do with T probably, I mean, we could not see the dreams, surgical dreams, whether it's inside or not. So we converted into T guided procedure. We did not have any major complications. There's no device embolization. There's no hemodynamic instability or significant arrhythmias, but 10 patients had multiple atrial premature complexes and 3 patients had a prolonged PR interval, but all the tension and substituted within 12 hours of the procedure. So there are studies earlier published with the TT and flow guidance. Our studies are different from that because our population is a younger population. That is 28% of them are less than 2 years and 16% of them less than 1 year. But other studies, they're up to 2 years they are enrolled. Conclusion, if ASD models are clear, use TT and flow guidance. If there is a difficulty in aligning LA disc when T is used, just pull up the T and probe, see that it's getting aligned. Our experience showed T probe may be a hindrance for LA disc alignment in some cases. And our study research showed high percentage of success with the TT and flow guidance when ASD margins are clear, even in small age groups starting from 7 months. Thank you.